We were previously talking about the COPD patient and the fact that there's two different branches from COPD. We have the chronic bronchitis and the emphysema. Here's a side-by-side comparison. The slang term pink puffer, blue bloater, pink puffer meaning emphysema, blue bloater. The reason that we use those terms is kind of identified by the differences. So pink puffer, no bronchitic component, whereas the blue bloater, it's chronic bronchitis, so that's where it starts, is in the bronchitis. Barrel chest, no barrel chest. Early dyspnea, late dyspnea here. Hunched over, whereas no air hunger here. Ventilation is okay in the chronic bronchitis patient, but hyperventilation is identified in the pink puffer. That's where we get the puffer. The blue bloater is going to have noticeable cyanosis, so that's where we get blue. And the bloat part comes from the fact that they develop cor pulmonale, right-sided heart failure related to pulmonary disease, which causes fluid retention. So the blue bloater is going to have fluid retention and possibly be obese, whereas the pink puffer might have a barrel chest, but other than that, going to have very thin extremities, and you can often see their rib cage poking out. So weight loss is associated with the pink puffer. Even though the two conditions are different, the medical treatment is very similar for both. The goal of medical treatment is to attain symptom relief, slow disease progression, and improve exercise tolerance, prevent and treat complications such as developing pneumonia, and improve overall health. The treatment plan begins with education and smoking cessation. The best thing they can do is stop smoking. After that, we can use drug therapy. They need to have an annual influenza vaccine and also a pneumonia vaccine if they haven't had that yet. But very important, these people are already having a hard enough time without having to deal with the flu as well. Bronchodilators are going to be used in both. Beta-adrenergic blockers, or beta-adrenergics such as albuterol, are frequently used. The anticholinergics are often more effective in COPD with fewer side effects, so that would be things like your Atrovent inhalers, although a lot of them use a Duaneb or Combivent, which is both the albuterol and the ipratropium. So it has both the beta-adrenergic and the anticholinergic. Xanthines are not commonly used with COPD. This would include things like theophylline. Inhaled corticosteroids are commonly used to reduce airway inflammation and reduce the number of exacerbations, especially when combined with other things. And inhaled corticosteroids don't have the side effects that are seen with the systemic corticosteroids. O2 may be in use, but it's going to be used cautiously. And let me get to the next screen here. This says, I have COPD. My carbon dioxide can be raised. Do not give me high flow oxygen. So low flow, only 24%. We're limited to 2 liters without a specific doctor's order telling us that we need to give them more. So low flow oxygen for the COPD patient. Chest physiotherapy may be ordered to help mobilize secretions. They might undergo pulmonary rehab for exercise reconditioning. Programs in pulmonary rehab are individualized but use a progressive exercise, either walking or pedaling a stationary bike. A typical program might have the patient walk 10 to 15 minutes every day or every other day and increase by 5 minutes every other week. The goal is to enable the patient to exercise comfortably for 45 minutes to 1 hour daily or every other day. Of course, some will not be able to achieve this, but improvement in walking and general health has been found in patients who consistently walk as little as 12 minutes every day for 2 months. And often bronchodilators are needed before exercise. Nutrition. Malnutrition causes decreased energy and a decreased resistance to infection, and so our emphysema patient is at risk for malnutrition just because it takes too much effort to eat and digest food, so they avoid it. On the opposite spectrum, obesity can increase the work of breathing, so we have to watch for obesity in our chronic bronchitis patient. There's not really a specific diet for either of these COPD patients. However, supplemental feeding such as Ensure may be needed with some patients, and there is a specific type. It's not Ensure. It's called Pulmicare. It's similar to Ensure, but it's specifically for pulmonary patients because milk products have been found to kind of increase mucus, and Pulmicare doesn't do that. So that is something that you might see for the emphysema patient that needs a little bit of extra supplemental feeding. Fluids, 2 to 3 liters a day to thin out those secretions. They might also benefit from using a humidifier. If the patient is unable to cough, then suctioning may be needed. Remember that one of the easiest things we can do is positioning. Positioning and O2 are 2 simple measures that can be instituted very quickly or promptly, as I have here, to treat dyspnea or shortness of breath. So let's look at some sample questions now related to the COPD patient. What is the recommended daily fluid intake to help thin secretions in the patients with impaired gas exchange? Well, in my lecture, I said 2 to 3 liters, so you have to do your conversion to come up with the 2,500 to 3,000 milliliters. The most serious complications of COPD are respiratory failure and what? And hopefully remember that fancy French-sounding word, cor pulmonale, which is a type of heart failure related to pulmonary failure or pulmonary disease. Excuse me. Which position should the nurse instruct the client with emphysema to assume that will enhance the effectiveness of breathing during dyspneic episodes? I didn't talk a lot about this, but I think I had a picture. One of the best ways to help the patient is to assume what we call a tripod position. And the tripod position has them supporting their chest using their arms. So they would be sitting up and leaning on their over bed table. A lot of times this can really support the patient who's having trouble catching their breath. If they're unable to do this, then we want them to sit up as high in the bed as possible. During the physical examination of patients with COPD, the thorax, or chest, is inspected for the classic what? Pink color, blue tinge, barrel, chest shape, or pulmonary edema. And hopefully you remember the picture of my pink puffer and a dinosaur that looked like it had swallowed a barrel. So barrel chest shape. The nurse instructs the client on pursed lip breathing and asks the client to demonstrate the breathing technique. Which observation by the nurse indicates that the client is performing the technique correctly? Well, we have to go back to several lecture segments where I talked about this, and I gave you an analogy. I said, pretend that you're smelling the birthday cake and blowing out the candles. So we're looking for smelling the birthday cake, which would involve breathing in through the nose, not the mouth, so that eliminates choice number 1, and then breathe out slowly through the mouth. We don't want to puff out our cheeks while we do this. And so there's your correct response there. The next disorder we're going to discuss is cystic fibrosis, and this affects other than the respiratory system, but we're going to focus on how it affects the respiratory system. So definition, cystic fibrosis is a hereditary disorder diagnosed in early childhood. It's characterized by a dysfunction of the exocrine glands and producing thick, tenacious mucus. So exocrine glands are glands that secrete mucus, sweat, saliva, and digestive enzymes. And so based on these secrete mucus, that's how it affects the respiratory system, digestive enzymes, so it's going to affect the digestive enzymes, and it also affects the sweat, which we'll talk about as a sign and symptom. It is something that someone is born with, and so the first sign may be a meconium ileus in the newborn. That means they don't pass stool within the first 24 hours of life. And this kind of gives you a picture of what that looks like. The first respiratory sign is a cough, eventually becoming thick, purulent sputum that obstructs the airways. It also obstructs the pancreatic duct so that the pancreatic enzymes cannot be delivered to the GI tract. And without pancreatic enzymes, patients cannot absorb proteins, fats, and fat-soluble vitamins. Their stools become bulky and foul-smelling. This is called steatorrhea, meaning undigested fat is in the stools. It can result in erectile prolapse, malnutrition, and failure to thrive as a child, and delayed puberty. In men, the vas deferens is absent usually, and so it results in infertility, and women have reduced fertility as well. These patients lose more salt in their sweat than normal, and so they are at risk for salt depletion, so low sodium and low chloride levels, which, if you remember from our previous lesson on fluid and electrolytes, we call that hyponatremia or hypochloremia. Their skin is very, very salty, and there is actually a test that we can perform that detects the amount of salt in their sweat that can help definitively diagnose this. It's called quantitative sweat chloride test, and it's often performed in infants younger than 3 months, again, if they're thinking that this might be the problem but they're not sure. Medical treatment focuses on preventing infection, as I have here. At one point in time, people with cystic fibrosis were unlikely to survive beyond the early childhood years. Improved treatments, however, have resulted in more people surviving into adulthood. It's now not uncommon to see adults living in long-term care settings with cystic fibrosis. So again, we're going to prevent infection, chest physiotherapy, all of those things, those three things that we talked about, the vibration, percussion, and postural positioning, are all frequently done with a cystic fibrosis patient. Forced expiratory technique, that's a type of breathing exercise. Bronchodilators, just like with the asthma or COPD. Supplemental oxygen. Monitoring for hemoptysis or blood in the sputum. I will briefly touch on how it affects the GI system because I'm not sure that we'll cover that when we do GI. These patients need a high-calorie, high-protein, well-balanced diet. Multivitamins are also administered. Monitoring weight is very important, and monitoring stool patterns for either obstruction, like in the case of the ileus that I showed you on the x-ray of the infant, and adequacy of pancreatic enzymes to absorb food. Usually these patients will take pancreatic enzymes, and these need to be given within 30 minutes of all meals and snacks. If they don't eat, they don't need to take their pancreatic enzymes. All these do is help them absorb the nutrients from their food. We also need to ensure adequate salt intake, which you have here. She's holding her salty snacks and her pancreatic enzymes. And ensure immunizations are up to date. Tuberculosis is a highly communicable disease caused by a bacterium, acid fast, if you want to be more specific. Tuberculosis is spread through droplets during coughing, laughing, sneezing, and singing. It used to be the leading cause of death in the U.S. until antibiotics were discovered in the 1940s. Since then, incidence has declined dramatically until 1986, when the numbers began to rise. The rise was attributed to drug-resistant strains, influx of immigrants, but probably more than anything else due to the HIV. People with HIV are bad about being carriers of tuberculosis. In 2008, the tuberculosis rate was 10 times greater in foreign-born Americans than those born in the U.S. People in California, Florida, New York, and Texas account for approximately half of all the cases in the U.S., and those 4 states are all heavily populated with immigrants. Even though the incidence has fallen significantly beginning in 1992, the number of new cases continues to rise in many areas. Anyone can be infected. Fortunately, most healthy people are not infected through brief contact. This is a map showing where the higher incidence around the world are of tuberculosis. So frequently, someone may be in contact with someone with tuberculosis. They're exposed. Body fights it off. In a healthy individual, that happens a lot. And so that's why a lot of times people will have a positive tuberculosis skin test come back and they've had no symptoms. Were they exposed? Yes, but their body managed to fight it off. That's why in the 80s, when we started having HIV and AIDS come, those people didn't have the immune system to fight off the tuberculosis, and that's one of the reasons why we saw a big increase in tuberculosis cases, is people with susceptible immune systems, instead of fighting off tuberculosis, it became active, and during the active phase, you're able to spread it from person to person. Frequently, when someone tests positive for TB exposure, we'll do an x-ray and it will reveal this granuloma, and that scar tissue that shows where the body has walled off the bacteria and basically fought off the disease. In some patients, however, the infectious process progresses and active tuberculosis develops.